Thank you so much for the opportunity, and thank you, Michelle. I think I'm almost too relaxed, so I might actually speak slower than usual, which is probably a good thing. But Sisi Pan, I'm the Chief Strategy Officer at Maisha Meds. I've been a global health practitioner, having lived half my career in Southern and East Africa. And I have been a global health practitioner and am one because I think too many people, particularly women and young girls, still needlessly today suffer or even die due to preventable causes. And I think the fact that this is true is actually an imperative that we need to work on. And as well, I think it compels us to imagine a system that actually serves everyone. So let me tell you a bit about how Maisha Meds tries to do that. So Maisha Meds is an African healthcare technology company operational across Kenya, Uganda, Tanzania, Nigeria, and Zambia. And in our markets of operation, I wanted to share that the private sector, which means mom and pop shops, small drug shops, pharmacies, small clinics, particularly in peri-urban and rural areas, this is the first and sometimes only point of healthcare for the vast majority of people, particularly women. And most of the people seeking care there will be uninsured. They'll only be able to receive the care they need based on how much shillings or naira they have in their pocket. It's very fragmented. And actually, a lot of the drug shops are also women owned. So this is sort of the context in which Maisha Meds works. Next. As a company, and we are founded and led by an amazing woman CEO, Dr. Jessica Vernon. But we are founded to try to solve some of the issues that I stated on the prior page, which is that we want to not only know what happens at the last mile in these more disparate peri-urban and rural areas, but importantly, we want to influence and improve the quality and affordability of care that people, particularly women, receive there. So there's three parts to the Maisha Meds technology solution. The first is that we have built business software exactly for those mom and pop shops, drug shops, and clinics so that they can move away from pen and paper operations and they can make sales, manage their product inventory, check their profit and loss, and really just run more fulsome businesses. And again, a lot of these drug shops are women owned, and this is their primary source of income. And in doing so, we've created a network of more than 4,000 such facilities, which is the largest digital network of its kind across the continent. But once we started doing that, we saw the data that was finally flowing through from the last mile, and we noticed there is a real opportunity to improve the quality and affordability of care. So we've built flagship patient support programs focused on malaria, which disproportionately kills women and young children, family planning, HIV prevention, and more. And this is really where we spend a lot of our time and energy, making sure that patients can get the care they need at the last mile. And last but not least, the third part of our technology solution is, everything I described generates real-time data that never before existed because it, again, used to be sort of on pen and paper. And not only does that inform how we build and improve our patient programs, but we also offer this data to governments in the countries in which we work, as well as global health funders, so that it can inform thoughtful policy change and program design. Next. As I mentioned, we have worked really hard to build already a really large network, and I want to just point out two things here. One, it's hard work, but we're really proud that our network is predominantly in peri-urban and rural areas in the countries in which we work, because that is where the need is greatest. I also want to share that we have logged 30 million patient visits today on our software, and that's just increasing exponentially. We record 1.6 million every month these days, and the overwhelming majority of those patient visits are from women. Next. I think one thing that's really important for us as we build our patient programs is not to say, wow, maybe sometimes the quality of care at the last mile isn't so great. Whose fault is that? That's just not our approach. I think at Maisha Meds, we really look at the evidence, but we also look at it with empathy. What are the actual human behaviors that happen at the last mile in perhaps a rural area between that pharmacist or that drug shop owner and the patient. And I just want to highlight one thing here because the evidence sometimes suggests that it's not what you think it is. So most family planning and contraceptive sales that happen in our country of operations happen in the private sector, not in like the larger government hospitals. And that's what you see on the left. And we've noticed that in our patient programs, if you hypothesize, why don't women, purchase more longer acting methods that are more effective for them and ultimately less expensive? Why is there so much purchase of emergency contraceptives? You could say, well, maybe the pharmacist just needs to dispense it for free. Maybe it's just that the patient can't afford it. We have to lower the cost more. But what we actually found in a randomized control trial is that bar you see all the way on the right, which is that what really happens at the last mile is an interaction. And if a pharmacist or an attendant or a women drug shop owner isn't compensated for her time, she may not be empowered or may not remember to provide counseling because she's incredibly busy and she knows an emergency contraceptive sale is one of her highest profit products. And so with a very small nudge and a thoughtfully designed care pathway using our technology, you actually see that a small fee for the attendant or pharmacist or drug shop owner's time is actually what increases almost 6x the uptake of long-acting contraceptive methods that is better for the woman patient in the end. So we just really wanted to share that. Grounding in evidence and empathy can really reveal a lot about human behaviors rather than, I guess, scolding them and wondering why outcomes aren't improving. So I guess this is a snapshot of what we do at Maisha Meds. I'm so happy to answer further questions, but I did want to share the ask or sort of where we're at in our current inflection point in growth. So we are extremely fortunate to have had some proven programs such as our family planning program I just described, but also HIV prevention, malaria, etc. And so we are seeking outcomes-based funding from global health funders, from philanthropists, etc., so that we can actually serve over 1 million patients every year through a transparent cost per patient basis. So that is something we're really excited to do. Hand in hand, we always try to think about incubating new patient program areas that really make sense alongside our existing programs. I think something that's giving us a lot of energy right now that we're deeply exploring are things in the maternal, neonatal, and child health space, as well as in the HPV space, which is severely underserved in our markets of operation. And lastly, if everything I described today is interesting, even if it's not just about our model, but maybe about a policy or a program question you have at your organization, we're really open to bring our data to bear and sharing it with you, because in the end, we can't solve every problem, but we believe all the problems as it pertains to women in the areas we work are important to solve. So thank you so much for your time.
Thank you, Sisi. I know you flew back from Nairobi and made all the way back here to pitch for us today. We really appreciate it. I think Donna has the first question for you today.
Wonderful presentation, Sisi. Thank you so much. To start off, I kind of have a set of combined questions. One is, how do patients discover Maisha Meds in the first place? And the second part is, what types, you gave a great example about the contraception, but I'm curious, what are the suite of services or offerings that patients typically utilize the most?
Very thoughtful questions, Donna. So one, patients discover us. Our philosophy is that we want to meet patients where they seek care. So we actually don't put it upon the patient to necessarily know, is this a Maisha Meds clinic or not? They are probably already going to their local drug shop, pharmacy, and clinic to receive care. We just provide the enabling software exactly for those providers to be able to give them better care. We are working with demand generation engagement tools whereby we might use short codes or WhatsApp, SMSs, etc., to contact different people. But I think in the case of privacy, especially for family planning and contraceptive care in particular, or HIV PrEP, we actually don't try to do that patient outreach. And we just meet patients where they seek care and hope that the providers there can actually provide better care. In terms of the suite of products, we have a malaria program, a fevers management program, a family planning and broader sexual and reproductive health program, an HIV PrEP or prevention program with new longer acting injectable methods that are coming online, We had a COVID vaccine program and so on and so forth. So it's all about if a patient is going to come to one of these pharmacies anyway, which is what they do anyway, we just want that suite of care to increasingly be covering most essential primary health areas and to be higher quality and more affordable without asking anything extra of them, not asking them to download anything, pay more, etc.
Just curious how you actually distribute the software in the first place. How do you go out and get these clinics and convince them to start using it? Do you have really strong ground game? How much pull is there from the clinics themselves?
Yeah, that we usually, there's usually 4 different methods or channels through which we acquire pharmacies or empower them. Number 1, we do have amazing staff in all of our countries of operations. And this is not just in the urban areas. In Nigeria, we're in the north where there's a lot of malaria. In Uganda, we're in the west, etc. So we do have sort of door to door, if you will, right? And a lot of that is really important for onboarding and training, even in terms of the digital and financial literacy of some of the drug shops and pharmacies that use our software. We want to make sure it actually adds value to them. But we also have referrals. It's also just our software is free to download and use off the Google Play Store. So we do also just have organic growth. But I think the 4th channel that's been really important, takes a lot of work, but is definitely one of the highest value, is that we partner with either appropriate local or regional associations, such as the pharmacist associations or the faith-based networks, which is sort of like the powerful and kind of convening nucleus in many of our countries of operations. And importantly, we partner with county or state and national level governments. Because again, we're not trying to build a parallel system. We're trying to bring online and improve the quality of care of healthcare infrastructure that already exists, but for so many years have been underinvested in because it's just not really possible since they're so fragmented.
Great. Well, thank you so much. And thank you to our judges.